sticking it into the actual tumor and burning the tumor. And basically, next slide. You do it on a CAT scan table. There's no surgery involved. There's no general anesthesia. You basically take a patient with a little lung nodule, and you see here on the CAT scan, here's the lung nodule. Here's the needle coming into it through a small, there's no incision, just putting a needle, a big needle through the skin. And the needle heats up to a temperature of 90 degrees, almost boiling water, and basically burns out the whole lung nodule and a little bit of normal lung around it. And if this is with your lung nodule beforehand, this is 6 months later, gone. Just goes away, it disappears into a star. It's not 100% effective. It's nowhere near as effective as conventional surgery, but compared to the old alternative, which was just external beam radiation, much more effective. And most patients are alive and well at 1 year, and we haven't been doing it long enough to know the true long-term results. But so far, the 3-year data, the 3-year results are pretty good, and so we're waiting for the 5-year results to come. You know, and we offer this at Maimonides. I do this myself. Other types of ablations, it's just basically the same kind of principle, using a different type of technology, using a different type of heat energy. It's microwave ablation, basically. It's a different kind of needle, but it uses microwaves to heat up the tissue, the same way your microwave at home heats up your dinner, but in a localized area. Next slide. This is sort of the future. It's not quite around yet, but we're sort of on board to developing this. It's called nanoknife technologies, basically electrocuting the tumor, putting an electrical energy into it and getting all the cells it makes holes in the actual cells. And when there's enough holes in the cells, they pop and die. And what's good about this that you can't do with microwave or radio frequency ablation is that you can do this next to big blood vessels, you can do this next to large structures, and it won't cause a lot of damage. It won't cause significant injuries. Thus far, it's been used very successfully with prostate cancers by some urologists, and only 2 cases in the world of lung cancer. I mean, we've done it in pigs and other animals and, you know, in the laboratory, and it seems to do the trick. 2 cases of lung cancer successfully treated so far with this in the world, and none of them are in the US. So it's sort of the future. It's still something to think about, but our gears are working. We as surgeons are trying to find newer ways to help those high-risk patients, and maybe one day trying to avoid big surgery. Next slide, please. Now, getting to that stereotactic radiosurgery, in 2012 we're opening a stereotactic radiosurgery center at Maimonides. Basically, what I mentioned before about radiation, if you shine radiation on the entire body will die. People get radiation poisoning, most of their cells stop working, and they die. So how do we deliver a higher radiation dose just to the area of the tumor without affecting the normal lung around it, the big blood vessels, the heart, any of these structures that can potentially be harmed by high doses of radiation that flow across them? Well, there's some cool new technology in the radiation world where we're able to do just that. We basically, go to the next slide and we'll come back to this one. It's basically a special room where you sit, where you lay on the couch. We implant tiny little metal, little gold, what we call fiducials. They're tiny little gold markers. We implant them using needles in and around the tumor. And you lay down on the table, and there's a cool X-ray that sits on the ceiling. And basically, while you're sitting and breathing, it tracks those 3 little metal markers in your chest and watches them move up and down as you breathe. And using a special robotic arm that can move pretty much in about 6,000 different ways, we can deliver small little shots of radiation right to that area of the tumor based on its tracking, and kill essentially the tumor, deliver a much higher dose to that tumor without actually affecting normal tissue. So you go back up one slide. So you plan it, here's a nodule, and you draw little lines here, and you can see your radiation doses are very high, just in the area around the tumor, and the radiation here next to normal structures and around the normal lung is almost nothing. And those people do very well. And the results of this have been quite encouraging in terms of our ability to treat those cancers for high-risk patients. Next slide, please, or two more? Yeah. Okay, so that's my spiel on the cancer. I just wanted to spend a couple of minutes talking about the other important stuff. So going back to the whole smoking thing. So prevention. Everybody talks about prevention. Don't engage in the high-risk activities, and it'll be better. It's very important to think about. Your doctor should be discussing it with you. We discuss it with all our patients. Smoking cessation, various ways, nicotine replacement, gum patch, new inhalational